두 번째 세션의 제목은 Future Direction of Antithrombotic Therapy After Cardiovascular Intervention이고 좌장으로는 서울대병원의 김효수 교수님, 인천성모병원의 전두수 교수님, 그리고 서울성모병원의 장기욱 교수님께서 자리해 주셨습니다. 김효수 교수님 부탁드리겠습니다.
Welcome to the second session under the title of Future Direction of Antithrombotic Therapy After Cardiovascular Intervention. This session is a 75-minute session. We have 4 lectures. Each lecture will continue 50 minutes, 2 from USA, 2 from Korea. I'm H.S. Kim from SNU Hospital. My co-moderator is Dr. Do-Soo Jeon and Ki-Yuk Chang from Catholic University Hospital. Let me introduce the first speaker, Dr. Roxana Maran. She's really a leader of this field in globally. She's now in Mount Sinai Hospital, USA. The video or lecture title is Balancing Benefits and Risks of Antiplatelet Therapies in Acute Coronary Syndrome, Filling Gaps in Evidence. Video, please.
Hello, it's my pleasure to bring to you from New York at Mount Sinai, Balancing Benefits and Risks of Antiplatelet Therapies in Acute Coronary Syndromes, Filling the Gaps in Evidence. These are my important disclosures. Let's talk a little bit about the ischemic and bleeding risk and then, of course, talk about some of the novel therapies that might uncouple this very, very entangled issue of ischemic and bleeding risk. The risk of the determinants of antithrombotic treatment in PCI and the choice of treatments have a lot to do with patient characteristics, clinical presentations, comorbidities, and the procedures, PCI versus CABG, femoral versus radial, and you know that the antithrombotic treatment has to do with balancing this risk of bleeding and ischemic events. There's no question that as you decrease ischemic risk, there's an expense of bleeding, and we've seen this in Triton, we saw it in Plato, and we continue to see this in multitudes of clinical trials. So very important. Every single time that we see new studies with new targets, we start to see more bleeding when we reduce ischemic events. And to get back to this, we have to kind of go back to the time course of bleeding versus ischemic risk after PCI. And that has to do with the local stent-related events, the plaque progression and destabilization outside of the stent, preventing those ischemic events that are completely outside of the heart, and then balancing that with bleeding. And dual antiplatelet therapy is trying to get to this important sweet spot, a spot where you have the least ischemic events with the least amount of bleeding. Can we ever get there? The other issue is that the patients are very different. Many of our patients have high bleeding risk, and these same high bleeding risk patients will also have a very high ischemic risk. And so balancing that becomes even a bigger dilemma. So if we look at the prognostic impact of bleeding versus MI, well, they both matter, and it all depends. MI is important, but it isn't as important as a BARC 3C and greater bleeding. It is also important to understand that the risk of mortality goes up every time you have a higher risk of ischemic events, as well as a higher risk of bleeding events. So you see on the right side that many of our patients are living in this horrific zone of higher morbidity mortality. So MI and bleeding risk are comparable. When we look at the complexity of our patient population, and if you have complex PCI, you have much higher rates of MACE. And in fact, in those patients with complex PCI, a longer duration reduces MACE in complex PCI, duration of dual antiplatelet therapies, because of the fact that the ischemic risk is that much greater. But this doesn't mean that it's okay to not think about bleeding, because bleeding matters. When you look at the high bleeding risk patients, there is no net benefit of long duration of dual antiplatelet therapies, irrespective of complexity. And it's really about the non-high bleeding risk patients where we start to see a very important benefit. And again, very important is the differences in the optimal therapeutic window of platelet reactivity between white and East Asian population. As compared to white males, East Asian patients have lower ischemic events, higher bleeding risk. So the bleeding risk becomes even more important in our East Asian patient populations. We have gone up and down this roller coaster in terms of the duration of antiplatelet therapies after PCI. We started when we were worried about thrombosis, then we became aware of the bleeding, and now we're at a level of equipoise with safer stent platforms, more imaging, more nuanced understanding of DAPT cessation, and important experimental approaches with shorter durations and even aspirin withdrawal. Who would imagine that we would withdraw aspirin? Well, makes a lot of sense. But the most important one for East Asians is the bleeding risk. But it's important that remember that the risk reduction that we used to enjoy in the past is no longer as profound as it was in the past, because we have so many other nice drugs that takes care of the baseline risk. And these novel antithrombotic regimens are really questioning and examining whether or not we actually need aspirin. In fact, the pharmacodynamic studies of aspirin withdrawal suggest that aspirin is doing nothing but increase bleeding. In fact, and very little additional platelet inhibition following stimuli when aspirin is present in presence of potent P2Y12 inhibitors. This is with Prasugrel by Paul Armstrong, but there are similar studies in ticagrelor. And in fact, because of that, there are so many clinical trials looking at aspirin-free strategies, and we thank our Asian investigators for really contributing tremendously with STOP-DAP2, Smart Choice, TICO, STOP-DAP2 ACS, with a lot of data now. And as you know, our group conducted the Twilight study for the very first time in a double-blind randomized controlled trial withdrawing aspirin in patients who would be on after 3 months of open-label aspirin and ticagrelor. And what we found that over a period of the next year after you enroll the patients, continuing with aspirin and ticagrelor exposes patients to 7.1% of BARC-235 bleeding, and this number decreased down to 4%, with the numbers needed to treat at 33 by just taking aspirin off. What happened to death, MI, and stroke was absolutely nothing. And in fact, we've concluded that in high-risk patients who underwent PCI were treated for 3 months of aspirin and ticagrelor without any major events, that the strategy of ticagrelor monotherapy gave less bleeding without increasing ischemic events. In fact, we saw this very much profound benefit in the acute coronary syndrome patients who came in, and we were able to receive a class 2A recommendation in these patients. We also saw in high bleeding risk and complex PCI that you reduce bleeding without increasing ischemic events in both of these populations. Very, very important finding. We had studied the ACS patient population, but the only group that we had not studied were STEMI patients. But our Korean colleagues in the TICO study did include STEMI and non-STEMI, and then they were very, very open to share the data with us, and we just presented this and published this in Circulation this past 2 months ago, where we combined this IPD meta-analysis of Twilight and TICO, individual patient data with all ACS patients, showing the incremental benefit of reducing bleeding without increasing ischemic events in these very, very difficult ACS patients. We also have some data on the importance of P2Y12 monotherapy after complex PCI. This is another IPD analysis led by my colleague, Dr. Marco Valgimigli, looking at a meta-analysis of 23,000 patients, 6 randomized trials of GLASSY, Smart Choice, STOP-DAP2, TYCO, and Twilight, showing similarly a very, very important benefit of reducing bleeding events without increasing ischemic harm, and in fact, having a positive outcome in net adverse clinical events in terms of P2Y12 monotherapy. For a long-term maintenance, the only trial that has looked at this is HOST exam, where they did over 5,000 patients. And again, our Korean colleagues did this work, and we thank them for this. And I believe that this is such an important study in patients who are event-free after DAPT, after PCI for 6 to 18 months, randomized uncouple the anti-side, which reduces the hepatic synthesis of factor 11, or antibodies that bind factor 11 and block the activation, and then some small molecules that bind reversibly at the active site of factor 11 and block activity. The programs are massive. There is the Librexia programs, the Ozalea and Lilac programs, as well as the Pacific programs, all of them taking on a very, very large scale of multitudes of patients at hand. Most of these are ongoing. The Asundexian Pacific AF program was the phase 2 program with 750 patients, showing complete inhibition of factor 11 with less bleeding. They had efficacy data that was lacking, and they took that on. The other phase 2 program was their Pacific AMI program. On top of DAPT, they showed a significant reduction of dose-dependent inhibition of factor 11A without increasing bleeding, but no clear signal towards reducing MACE, very few MACE events, and they're waiting to see if they will go ahead. We do know that Pacific Stroke program, that phase 2 program, also was done with asundexian that reduced ischemic strokes among patients with atherosclerosis. They have 2 phase 3 programs, Oceanic AF and Oceanic Stroke. We all know that Oceanic AF was stopped prematurely after 13,000 patients were enrolled for lack of efficacy, but Oceanic Stroke is going forward. Milvexian in stroke has been very well. This is another small molecule by that's being evaluated by in this axiomatic study, the SSP study, where there was symptomatic ischemic stroke, different dosing, multitudes of different dosings with very, very little impact on bleeding, and very important association, found no fatal bleeding. The Librexia program is extremely large, a stroke program, an acute coronary syndrome program, and an atrial fibrillation program, all encompassing about 50,000 patients in these programs ongoing. The monoclonal antibodies, abicilimab, was evaluated in VTE with excellent results, no bleeding, and in the ongoing atrial fibrillation trial, Ozalea was just presented at the AHA showing fantastic, no bleeding issues and very, very good results. And the Lilac study with patients in AF and moderate to high risk ischemic stroke is ongoing. So the take-home messages, ladies and gentlemen, the present-day antithrombotic therapies are working well. They are reducing ischemic events, but it's always as a very important expense of bleeding. Balancing ischemic and bleeding events are extremely important and ever so crucial. And at the moment, these emerging antithrombotic regimens, especially in factor 11 inhibition, show very promising results in uncoupling ischemic and bleeding risk. I want to thank you for your attention, and I look forward to the discussion after this presentation. 감사합니다.
Thank you for nice lecture, Dr. Meran. We are going to have a discussion after final lecture. Next speaker is Georgie Dengas from Mount Sinai Hospital. topic is either antithrombotic strategies after TAVR. Do you need more trials? And please, Dr. Dangos.
Dr. Dangas, we can.
Hello, everyone, and thank you very much for inviting me to give you this short presentation in a subject that is very interesting to me, but also very interesting to many of you, if not all of you in Korea, since you have contributed a lot in this field. In general, when we talk about the risk of stroke, because at the end of the day, that's what we're talking about when we're trying to deal with antithrombotic therapy and TAVR, we're dealing with the risks related to aortic atheroma, new-onset atrial fibrillation, and leaflet thrombosis, and the interplay of those three with each other. And we also deal with the interplay of the possible medical therapies, antiplatelets or anticoagulants, or the combination, or perhaps only monotherapy of each one of them, in combination with valve-related factors and patient-related factors. And we try to make some sense out of that and figure out which patients and which drugs might be suitable for what type of post-procedural course. The field was shocked by images. And it's really this field in many ways have been shaped by imaging. And you can see here images of so many valves, either surgical or bioprosthetic transcatheter, that indicate clots. And it's not like those things never existed before, but we just couldn't see. In the CT video, the so-called 4D CT angio, that shows now is able to show the valve opening and closing throughout the cardiac cycle, enables this type of investigation. And initially, of course, in the absence of previous data of any sort, I think our community was sort of clots sitting on top of the valve and having an impulsive way to try to get rid of them, in obviously employing some part of empiric antithrombotic therapies. And indeed, there were some registries and case reports, etc. They got a lot of publicity because it was, I would say, a shock finding. And they indicated that, again, in a registry mode, that if patients were not anticoagulated, there might have been some progression, but if they were anticoagulated, there was some regression. And this was the initial kind of thinking that perhaps should anybody have some form of anticoagulation regardless anything else. Over time, and we learn, and this includes now the latest study that included also surgical valves, that this problem is not specific to transcatheter valves. Maybe it appears a little bit earlier in the transcatheter valves. You can see on the left side in the randomization of a balloon expandable valve in surgery at 30 days, at 1 month, there seems to be some perhaps greater rate with the transcatheter valves, but at 1 year, there is a catch-up with the surgery as well, and there is a 20 to 25% rate of this type of phenomenon of finding in the valve some clots in the valve, and the 20 to 25% of patients is really no small percentage. The other interesting part is that this phenomenon fluctuates. So it's not the same people who have the clot at 1 month, those who do have it at 1 year, plus some more. Not at all. Some of them who have it at 1 month may or may not have it at 1 year, and those who don't have it at 1 month, they may develop it at 1 year. So not only is a phenomenon rather common at 1 year, but it also fluctuates. That is a very, very important, fluctuates like on its own, or with no modification on medical therapy. This is very, very important when we try to study this phenomenon, to not underestimate it, but also understand how dynamic this may be. It took us several years to come up with a very crisp definition of the stages, the grades of how important this phenomenon is, a reduced leaflet motion. And you can see At the bottom picture, schematically, how one can see the cup, that essentially every leaflet is a cup, and how full the cup is with clot. And the more clot there is, the more inflexibility occurs in the specific leaflet. And then you can have a valve analysis, a patient analysis, or you can even have a leaflet-based analysis if you want to really have a lot of observations by the CT angiogram. And of course, in looking at the valve itself and other leaflets, we showed for the first time that very clearly even a medium dose of coagulation, intermediate dose of 10 milligrams of rivaroxaban was highly effective in preventing this clot. Highly effective. Something that was new. Initially, everybody thought that only high doses anticoagulation would do this type of job. Unfortunately, we realized that when we're treating everyone with this type of therapy, namely with rivaroxaban, we end up having some untoward events in the entire population, although we had beneficial effects at the level of the valve, with increased MACE and mortality, as well as major bleeding, particularly at 1 year. Therefore, we're successful in something, but not really successful in the overall balance of thrombotic and bleeding risk in those patients, because bleeding is an important aspect early as well as late prognosis after TAVR. And in our analysis, we found that thromboembolic events and bleeding had a lot to do with mortality as well. The guidelines, for the most part, have American and European guidelines have gravitated towards simplicity in the absence of very definitive trials. You can see the 2021 guidelines. In general, one of the largest studies of patients with no anticoagulation is this pilot, essentially, study of 200 patients, 111 per group, the ARTE trial, that indicated no major benefit of adding clopidogrel, at the same time no major risk, but clearly everybody in this study, and this is a difficult analysis because everyone was preloaded with clopidogrel loading dose. Therefore, a lot of the upfront bleeding had a lot to do with a loading dose, which no longer used anywhere, I don't think, rather than the daily dose afterwards that would be geared more towards the durability of the valve. Another interesting European study was the study of Dutch of Holland that indicated that there's a lot of bleeding up front related to the loading dose of clopidogrel, but again, no difference between the two groups afterwards as the study follow-up evolves. Interestingly, on the right side, you can see that the aspirin alone group, those people who never received any clopidogrel, do have an accumulation of events over time, and the slope of accumulation of those events is somewhat different. No other study has performed this type of analysis, so we don't really know if this is a true finding or if this is something that is just a play of chance in this Dutch trial. For sure, the popular trial, the POP-TAVI, indicated that if you keep simple with the anticoagulated patients, there's no need to add clopidogrel to anticoagulation. At the same time, it did show that if you anticoagulate patients with an oral agent before the procedure, as this investigators mostly did, you're going to have a lot of bleeding, 10 and 20% from the get-go, as you can see on the left side. This is astoundingly high numbers of major bleeding, and for this reason, I don't think many people, many centers, so we certainly don't, treat with oral anticoagulants ahead of the procedure. So there were dual, I would say, lessons from this study. Avoid the oral anticoagulants before the procedure, and no need to add clopidogrel to the oral anticoagulant. The French study came with the Atlantis trial with a little bit of a mixed group these investigators gave a full dose of apixaban, not the low dose rivaroxaban we had investigated with, and they had dual comparisons. So I'm going to present those separately. The smallest study included just about 200 patients each for those who had indicated for oral anticoagulation, apixaban versus warfarin, essentially. The situation was just rather similar. When we go to apixaban versus antiplatelet therapy, though, in patients who didn't have an indication for oral anticoagulation, we have a clear repetition of the lessons from Galileo trial that indicate a higher mortality, non-cardiac and otherwise, with the anticoagulation versus the simpler antiplatelet therapy. There is some aspects of, again, benefits from the clotting in the valve, as you see at the bottom, but clearly doesn't outweigh the clinical adverse events. The overall results of the CT sub-study of the Atlantis, I don't think is of any news. Overall results were not so significant because in the anticoagulated group, somehow apixaban didn't do as well as warfarin, whereas in the non-anticoagulated group, it did quite a bit better than the antiplatelet. So there was some interaction there, but the overall results not so significant. Interestingly, these investigators showed that even in the presence of a significant clot in the valve, we didn't seem to have any adverse event within a year. So if someone was to ask or be nervous, why would the clot travel? Where could the clot travel? Well, it could travel anywhere, but apparently it doesn't seem to travel very much so towards the brain that we always are afraid of, and particularly so it may be related more so with the later adverse events of the valve, like the durability of the valve. Same way, perhaps a squeaky door that if you don't oil it, it may malfunction in some time. But there doesn't seem to be any immediate danger of this clot dislodging from the valve towards the brain, and that is very reassuring. In the envisaged TAVI-AF trial, we investigated with the edoxaban, and were able to show very clearly that was a non-inferior. You can see, as far as the NACE is concerned, the net adverse clinical event of both ischemia and bleeding, you can see the curves are superimposed. But on the right hand, you can see that with a prolonged administration, particularly beyond 1 year, we have to be careful, as there was some bleeding, particularly GI bleeding, and mostly, as we know from secondary analysis, those that were treated with antiplatelets, as well as those who may have specifically AVM-related bleeding sources. Interestingly, we're able from this study to identify that the type of atrial fibrillation, the creatinine clearance, the age, and the various other aspects, including the excessive alcohol utilization, had a lot to do with predicting the mortality, and we'll be happy to present a similar analysis for a risk score for a bleeding in the next year, which we're conducting right now. In summary, I want to also include the study that you all know very well, because it stems from your own country, the ADAPT TAVR, and about 110 patients per group of a edoxaban versus dual antiplatelet therapy, and a dedicated CT at 6 months after TAVR, as well as serial brain imaging. We experimented with brain imaging in Galileo as well. There's just a scattergram of those findings in the brain MRI. It's always very difficult to have a very significant and clear message from the brain MRIs. For the most part, this reports of functional studies and the way the MRIs are analyzed in the brain, I'm not so sure we have a very good grasp of what these findings mean, and I'm not sure we have a capacity to analyze them very well. Interestingly, there was some reduction in the event rate, but overall things did not go in the significant range, perhaps because the study was rather perhaps a little limited in numbers, slightly smaller than some of the other studies I presented before, and maybe that was a difference here. But or perhaps the dosage did not work so well of edoxaban in the patients studied. But in general, I would say the flavor is just about the same. That is a reduction of those events with edoxaban versus antiplatelet therapy. Again, this is the MRI studies that I'm not surprised in the Bravo trial with the Angiomax or Beverly-Rudin. During the procedure, we were also puzzled about how the best way to analyze that. We had a secondary analysis of MRI in Galileo, very similar results. Interesting, yet a little bit all over the place from analysis point of view without a very clear finding, despite the big efforts of everyone to ascertain the MRIs in this very difficult population. So overall, a few things we do know and we have learned is that even low-dose anticoagulation is effective against the TAVI leaflet thrombosis. We also know that the monotherapy seems to be the most reasonable and practical option at this time where anticoagulation is needed. But if anticoagulation is not needed for any other reason, we don't need to bother anymore. And as well as we don't need to bother loading, and we should not load with clopidogrel before the TAVI. And if for any reason we employ a combination therapy, perhaps it was a recent stent or a concomitant stent or something like that, then we have to really reevaluate at every clinic visit the strategy of continuing the combination anti-thrombotic antiplatelet therapy, or we should just simplify it as soon as we can and following this tailored approach. And hopefully we try collaboratively to conduct further studies to clarify where we may be going in this very complex field, but in my mind, very fruitful for international collaboration and research, because a lot to do with the durability of the valve have to do about how well oiled all those, I would say, leaflets may be, particularly in the hinge points. Same way, we want to keep our doors not squeaky when we open them. Thank you so much for your attention, for the invitation, and I hope we see all of you, or most of you, in the Sky Scientific sessions for the West Coast, Los Angeles, this coming May.
Thank you, Professor. That's the lecture. We're going to have a discussion after 2 more lectures. Please stay on the line. Next speaker is Juyong Han. Han Juyong. Topic is optimal antiplatelet therapy in East Asian patient. How to adapt to 2023 ES guidelines into East Asians. Please, Dr.
Thank you, Chairman. Good morning, everyone. I'm Juyong Han from Samsung Medical Center, Seoul, Korea. I'm very glad to be here, and thank you for inviting me to this wonderful meeting. These are my disclosures. Recently, European Society of Cardiology published guidelines for ACS. The antithrombotic therapy, including anticoagulation and antiplatelet therapy, is a cornerstone treatment for ACS patients. However, I would like to focus on antiplatelet therapy today due to time limit. Let's start with pre-treatment. That is, timing of loading dose of oral antiplatelet therapy. In patients with suspected STEMI, there is only one relevant RCT so far. In the Atlantic trial, there is no significant difference in MACE and bleeding between pre-hospital versus in-hospital ticagrelor strategy. However, the incidence of stent thrombosis in the pre-hospital group is significantly lower than in the in-hospital group. The median difference in the timing of loading between the two groups was 31 minutes. In patients with non-ST elevation ACS, data are also very limited. There is no benefit with the pretreatment of prasugrel in terms of ischemic events, but bleeding was increased with the pretreatment of prasugrel. In the ACOS trial, there's published in New England Journal of Medicine 2013, The median time from first loading dose to the start of coronary angiography in the pretreatment group was 4.4 hours. Moreover, pretreatment with ticagrelor was inferior to deferred prasugrel loading in the ISARVECT-5 trial. Therefore, ESC guidelines recommend a routine pretreatment of a P2Y12 inhibitor was as a class 2B for patients undergoing primary PCI, and as class 3 for patients with non-ST elevation ACS. The next topic is choice of P2Y12 inhibitors in ACS. As you well know, potent P2Y12 inhibitors, prasugrel and ticagrelor, beat clopidogrel in patients with ACS in large, well-conducted randomized trial, such as Triton-TIMI-38 and Plateau. However, until very recently, there is no direct comparison between two potent P2Y12 inhibitors. In the ISARVECT-5 trial, prasugrel was compared with ticagrelor in a broad spectrum of patients with ACS. For patients with STEMI, both P2Y12 inhibitors loaded immediately after randomization, while in patients with unstable angina or non-STEMI, ticagrelor was immediately loaded after randomization, but prasugrel loading was deferred after angiography. At 12 months, the incidence of primary endpoint, defined as composite of death, MI, or stroke, was 9.3% with ticagrelor and 6.9% with prasugrel. The difference was statistically significant. Notably, deafened stent thrombosis occurred less frequently in the prasugrel group compared with the ticagrelor group. There is no significant difference in terms of bleeding between the two groups. Therefore, ESC guidelines recommend prasugrel or ticagrelor in preference to clopidogrel as class 1 in patients with ACS. Clopidogrel is recommended if prasugrel and ticagrelor are unavailable, contraindicated, or cannot be tolerated. This recommendation is class 1. They also recommend if patients proceed to PCI, prasugrel is preferred to ticagrelor as class 2A. They still recommend the standard dose of prasugrel, loading dose of 60 milligram, followed by a maintenance dose of 10 milligram, and the ticagrelor, loading dose of 180 milligram, followed by a maintenance dose of 90 milligram BID. The most tough topic is duration of DAPT after ACS. The American guideline recommend DAPT of aspirin plus clopidogrel for 6 months in CCS patients and DAPT of aspirin plus P2Y12 inhibitors for 12 months in ACS patients. The ESC guidelines also recommend DAPT of aspirin plus P2Y12 inhibitor for 12 months as a default DAPT strategy after ACS. Again, clopidogrel is only recommended for a 12-month DAPT if prasugrel and ticagrelor are not available, cannot be tolerated, or are contraindicated, and may be considered in older ACS patients, typically defined as older than 70 to 80 years of age. However, various antiplatelet strategies to reduce bleeding risk after ACS have been proposed. They made some comments on this issue. The first strategy is shortening of antiplatelet therapy. They recommend in patients who are event-free after 3 to 6 months of DPT and who are not high ischemic risk, single antiplatelet therapy preferably with the P2Y12 receptor inhibitor, should be considered as class 2A with the level of evidence A. Let's look into the evidence. This slide summarizes recent RCTs and 3 to 6 months DAPT followed by aspirin. Of this, I would like to introduce SMART data, the largest, and was conducted by our group. This was a prospective, multi-center, randomized, and open-label trial. 2,700 patients with ACS undergoing PCI were randomly assigned either to 6 months DAPT group or 12 months or longer DAPT group, standard DAPT group. The primary endpoint was 18 months MACCE, defined as a composite of all-cause death, MI, or a stroke. At 12 months, the incidence of primary endpoint, MACCE, was 4.7% in the standard DAPT group and 4.2% in the 6 months DAPT group. The non-inferiority was met. However, landmark analysis showed the strong tendency of increased incidence of MACCE in the 6 months DAPT group compared with the standard DAPT group. Especially, MI significantly increased with the short DAPT followed by aspirin. What about the trials on P2Y12 inhibitor monotherapy? Of several trials, including Twilight trial that was conducted by Dr. Roxana Maran, only TICO trial exclusively enrolled ACS patients. In this trial, 3 months DAPT followed by ticagrelor monotherapy was compared with conventional ticagrelor-based 12-month DAPT. The primary endpoint was net clinical adverse events at 12 months, defined as MACCE plus TIMI major bleeding. At 12 months, the incidence of NACE was 5.9% in the standard ticagrelor-based 12-month DAPT group and 3.9% in the ticagrelor monotherapy group. 3-month landmark analysis showed consistent findings. However, caution is needed for clopidogrel monotherapy. In the STOP-DAPT-2 ACS trial, the researchers compared 1 month DAPT followed by clopidogrel monotherapy with the 12-month DAPT after Xience implantation for patients with ACS. In this trial, achievement of non-inferiority was failed, mainly due to increase in MI in the 1 month DAPT group compared with the 12-month DAPT group, while bleeding was significantly reduced by 1 month DAPT group. So taken together, short DAPT followed by ticagrelor monotherapy is promising, but aspirin or clopidogrel monotherapy needs caution in ACS. The next strategy is de-escalation of P2Y12 receptor inhibitor treatment. That is, switch from prasugrel ticagrelor to clopidogrel. This strategy may be considered as an alternative adaptive strategy to reduce bleeding risk as class 2B. The most relevant trial was TALOS-MI trial that was conducted by Dr. Gi-Yuk Jang, the chairman of this session. In this trial, the patient was randomly assigned either to aspirin plus clopidogrel or aspirin plus ticagrelor after 1 month common aspirin plus ticagrelor DAPT. At 12 months, the incidence of a primary endpoint, composite of CV death, MI, stroke, and bark bleeding, was 8.2% with the standard DAPT group and 4.6% in the de-escalation group. The difference was statistically significant and non-inferiority was met. In secondary analysis, the there was no significant difference in the ischemic events, but the bleeding was significantly decreased with the de-escalation strategy as expected. The other option is the dose reduction. The host-reduced polytech ACS trial that was conducted by Dr. H.S. Kim, another chairperson in this session. The reduced dose of Prasquil was compared with the standard dose Prasquil, 5 milligram to versus 10 milligram after 1 month common aspirin plus Prasquil DAPT. At 1 year, the incidence of a primary endpoint defined as net adverse clinical events was 7.2% in the de-escalation group and 10.1% in the conventional group. The non-inferiority was achieved, and the hazard ratio was significantly lower with the de-escalation group than in the conventional group. In the secondary outcome analysis, there is no significant difference in terms of ischemic events, but bleeding was significantly decreased with the de-escalation strategy. However, the incidence of major bleeding was very low in both the groups, and there was no significant difference between the two strategies. The other issue is HBR patients. They recommend in HBR patients aspirin or P2Y12 receptor inhibitor monotherapy after 1 month of DAPT may be considered as class 2B. In the master adaptive trial, patients at increased bleeding risk who underwent PCI were randomized to an abbreviated antiplatelet therapy, stopping DAPT and continuing single antiplatelet therapy versus a standard antiplatelet therapy, DAPT for 5 months if no indication for oral anticoagulation, or DAPT for 2 months if an indication for oral anticoagulation. At 11 months after randomization, the incidence of net adverse clinical events was similar between the two groups, 7.5% versus 7.7%. There is no significant difference in ischemic events, but bleeding was significantly decreased with the abbreviated antiplatelet therapy. In summary, abbreviated DAPT was non-inferior to standard DAPT regarding net NACE and MACCE, and superior regarding major bleeding. This was not a dedicated trial for ACS patients, but in the stratified analysis according to MI, the results were consistent. There are several strategies have been tested to reduce the risk of bleeding after PCI. Most strategies seems to be successful. However, 6 months DAPT followed by aspirin monotherapy, and 1 month DAPT followed by clopidogrel monotherapy needs caution. The other issue, the risk profile of enrolled patients. Of these 5 trials, only SMART-8 trial failed to non-inferiority in terms of MI. This difference may be attributable to the difference in antiplatelet strategy. However, as you can see here, the incidence of all-cause death and cardiac death was highest in the SMART-8 trial compared with the other trials. So the difference in these results might be attributable to risk profile of enrolled patients at least. In my opinion, the most important issue is the antiplatelet therapy beyond the 12 months. The ESC guidelines aspirin monotherapy as a default strategy beyond the first 12 months after ACS as class 1, but there is limited data on this issue. So far, the only one relevant trial is a host exam trial led by Professor H.S. Kim. In this trial, they enrolled more than 5,500 patients who were event-free under DAPT for 6 to 18 months. At 12 months, the incidence of the primary outcome defined as NACE was 5.7% with clopidogrel and 7.7% with the aspirin. The difference was statistically significant. The clopidogrel was superior in ischemic composite outcome as well as bleeding outcomes. This was a very interesting results. Our group also conducting Smart Choice 3 trial. In this trial, we enrolled more than 5,000 patients being treated with the standard duration of DAPT at high risk of recurrent ischemic events after PCI with DES. We compared clopidogrel monotherapy with the aspirin monotherapy. The enrollment of patients was completed and the results will be available in early 2025. The last topic is patients receiving OAC. The ESC guidelines, the very short duration of TAT, DAT of OAC plus clopidogrel till 1 year, and beyond 12 months, they recommend OAC monotherapy based on the results of a FIRE trial. In summary, my adoption strategy is very simple, just to follow it. So my choice of P2Y12 inhibitor is Prasugrel, unless patients have a contraindication or a caution. And my treatment strategy is Prasugrel loading for STEMI patients, typically at ER, and after confirmation of PCI indication in non-ST elevation ACS patients, unless CAG is expected to be postponed. My default antiplatelet strategy for the 12 months after ACS is aspirin plus P2Y12 inhibitor, preferably Prasugrel. If HBR, I reduce the dose of Prasugrel or change it to clopidogrel. My default antiplatelet strategy beyond the first 12 months after ACS is aspirin monotherapy so far. However, clopidogrel is frequently used for patients with AMI, DM, or complex lesions. My default anti-PLT strategy in patients with ACS and an indication for OAC is a very short period of aspirin, followed by clopidogrel plus NOAC, and NOAC only beyond 1 year. But I still continue clopidogrel in patients undergoing very complex PCI beyond 1 year. Thank you for your attention.
Thank you, Dr. Han. So we are waiting for next topic. So the next topic is conducted by Dr. Kang Ji-hoon of Seoul National University Hospital. This topic is aspirin versus clopidogrel for long-term maintenance monotherapy after PCI, generalizable or limited to East Asian patient. Dr. Kang, please.
Thank you for the kind introduction. My name is Ji-hoon Kang, and I work at Seoul National University Hospital. It's an honor to have us speak at the Winter Coax Symposium, and I thank all community members for inviting me. Today, my topic is going to be, as you see, aspirin versus clopidogrel in long-term maintenance monotherapy after PCI, and I'll focus on the fact of generalizable or limited to East Asian patients. First, as a short introduction, we all know that long-term management is very important, not only limited to antiplatelets, but also other risk factors that we consider as high-risk patients for coronary artery disease. Usually, most studies have focused on within 1 year post-PCI, which was nicely presented by Dr. Han. And we know that the bleeding risk is the main contributor in the antiplatelet therapy, which was also mentioned by Dr. Meran in the first topic. However, limited evidence is shown how should we treat patients post-PCI after the first year. So regarding the guidelines, we can see that aspirin monotherapy lifelong was recommended as a class 1 level of evidence A. It is interesting to see that the level of evidence is A, despite that we have no randomized control trials that have compared aspirin versus other alternative treatments that we have in the current era. Regarding the recent 2023 ESC guideline, we see that the class 1 is still consistent, while aspirin is recommended the first-line therapy in long-term management for antiplatelet therapy. However, regarding the position of aspirin, it's clearly on controversy, both on efficacy and the safety. Can aspirin decrease thrombotic events, which is an efficacy issue? This was lightly shown in the ARRIVE ASCENT aspirin trial, which was also, this was primary prevention patients, but it showed that aspirin had no effect in the efficacy aspect, while there was a consideration of high bleeding risk in those who are quite healthy. That means that who are in the primary prevention era. This can be extrapolated to the patients in the secondary prevention era, which means that aspirin may not be efficacious in those in secondary prevention. Regarding the safety issue, we all know that the aspirin has many aspects in the safety issue, which can be represented as the high bleeding risk. And are these safety issues, should these be tolerated when aspirin has a minimal effect in the efficacy? This is a very important issue that we should consider. There has been a lot of trials that have evaluated aspirin versus clopidogrel. Most were conducted in the long term, in quite a long time ago, or retrospective studies, but all showed that clopidogrel was better than aspirin compared to a lot of aspects. So I would like to state that the stature of aspirin, which is threatened right now, was not by an ethnic issue, and clopidogrel as an alternative aspirin was not also raised by Asians, because this is my topic today. So based on this kind of hypothesis, we did the HOS exam trial, which was presented in the previous session, and I would like to just fly through the results. This was a randomized control trial which compared aspirin versus clopidogrel in stable CAD patients. That means that these patients were event-free during the first year after PCI, and these patients needed a lifelong antiplatelet agents to prevent any kind of secondary events. The events showed that clopidogrel was superior compared to aspirin with a risk difference of 2%, which means that the number needed to treat was 50, which was a quite small number. Thrombotic endpoints and bleeding endpoints were both superior for clopidogrel compared to aspirin, which is a very interesting finding that we see in a lot of antiplatelet studies these days, showing that a single therapy is better in both thrombotic and bleeding endpoints compared to the comparator arm. This was also extended to a six-year follow-up, which was named as the HOST exam extended trial, which showed that, which compared the aspirin and clopidogrel arm for a long-term period. Because this study was done on a per protocol analysis, we can see that the number were quite slightly decreased, but still a majority of the patients were followed up during the 6-year follow-up period. Interestingly, also, we could see that because this was a PP analysis, from the ITT analysis, we could see that a larger number of aspirin patients were converted to clopidogrel due to various causes. In the extended arm, we could see that still during the 6-year follow-up period that the clopidogrel arm was superior compared to the aspirin arm, which was consistent in the landmark analysis, again showing that long-term management is very important in the CAD patients that we treat. Also in the thrombotic endpoint and bleeding endpoint, we could still see that clopidogrel was better than aspirin, showing that the superiority of clopidogrel compared to aspirin was not an incidental finding that was found in the early period after PCI, but it was accumulated during the long-term period after PCI, showing that clopidogrel might be a better agent compared to aspirin in treating patients in the long-term period. Also, in the mortality issue, there was a slightly reduction, though not statistically significant, by aspirin compared to clopidogrel in the 2-year follow-up period. But regarding the long-term period, we could see that there was no difference in mortality issue, which shows that clopidogrel and aspirin, there's no difference in mortality in the stable CAD patients that we treat for secondary prevention. So then the remaining issues is the ethnicity. Is ethnicity an important issue when we should consider these kinds of agents? Because obviously a lot of trials are performed in a certain aspect of the world, and can we apply these kinds of results to other ethnicities? So first, to go into this issue, if we want to say that this is not applicable to other ethnicities, this is making a statement that there is a potential difference across ethnicities, which is very large. That means that ethnicity is one of the major contributors that we should consider when determining a certain treatment. However, in the guidelines, again, ethnicity or race is a very seldomly stressed issue in the guidelines. All stress, ischemic risk, bleeding risk, and sometimes the minority ethnicity may be considered as an aspect, but it's obviously not a very major issue. Also, we know that a lot of trials are done in a single ethnicity, but also a lot of trials are done in a multi-ethnicity. So in these kinds of trials, how can we interpret the results if ethnicity were to be a very important issue? Of course, ethnicity could matter in comparison of two antithrombotic therapies with different ethnic intensities, such as, well, let's say dual antiplatelet therapy compared to single antiplatelet therapies, because a certain ethnicity may be slightly more ischemic or slightly more prone to bleeding. However, the comparison aspirin versus clopidogrel was not this kind of issue. Also, this may matter when we compare a single diagnostic measurement as a cutoff value, such as a PRU value. But again, aspirin versus clopidogrel is not an issue that compares a single diagnostic measurement. Also, regarding ethnicity, if we go in one step into ethnicity, what is ethnicity? Can we define ethnicity as a very important issue? If the ethnicity is very diverse, is there a single ethnicity? Can we define a single ethnicity by the skin color? Of course not. Also, we can see from this slide that most of the patients are worldwide are definition-wise Asian patients, but within Asian, there's Southeast Asian, there's Northeast Asian, there's Central Asia, which are very different patient populations. We can see that the Homo sapiens has moved a lot around the world, which shows that it's very difficult to define ethnicity. And also, even in the US, we all know that the US is a multi-ethnicity country. However, the white people are decreasing. And again, the white is not an ethnicity. This is just skin color, which is very different from ethnicity. So I would like to state that in the guidelines, ethnicity is a very minor issue, while the high-risk group is a very important issue, which is stated much more commonly in the guidelines, and this can be answered by subgroup analysis of the host exam or extended trial. So regarding the high-risk population, we all know that ACS and CCS is a very important issue in determining the intensity, determining the duration of antiplatelet therapy. Then is the initial presentation of ACS, is this any major determinant in the antiplatelet therapy after the patient is stabilized? So within the host exam trial, we did a subgroup analysis which divided those patients with ACS and without ACS. From this analysis, we can see that there is no difference, which means that the P4 interaction is very negative in regards of the primary endpoint, despite the patients with ACS or non-ACS, comparing aspirin versus clopidogrel, which can be interpreted that clopidogrel's monotherapy is superior compared to aspirin therapy, despite the initial presentation of ACS. Going into the thrombotic and bleeding endpoints, we can see that, again, the P4 interaction was negative in both endpoints. But in subgroup, if we go in one step into the results, we can see that in the ACS group, the reduction of thrombotic events was much more higher, while in the non-ACS group, the reduction in the bleeding endpoint was much more higher, which shows that probably clopidogrel could reduce the more important outcomes in ACS patients, while it could be more protective in the non-ACS patients in regard of bleeding events. So when we go into risk again, we think about the thrombotic risk, which can be defined as the ischemic risk, or the bleeding risk in patients. And again, this was a sub-study that was done in the host exam trial. And regarding the stable patients, we could see that the high thrombotic risk had no difference in clinical outcomes, which means that after the patient is stabilized, there is no difference in the thrombotic risk, regardless of the thrombotic risk in patients. However, in the bleeding risk, we could see that clinical events occurred more oftenly in the HBR arm, which showed that in stabilized patients, the bleeding risk is much more important in the long run. If this was if this was divided into thrombotic and bleeding events, we could see that the HBR arm had a higher event rate of thrombotic composite endpoints and bleeding endpoints, which can also be shown that the HBR population is not only a high bleeding risk population, but also a high thrombotic risk population. The HTR arm, we could see that there was no difference in thrombotic endpoints. And also interestingly, we could see that the HTR arm had a slightly higher event rate of bleeding events, which also shows that the HTR and the HBR are a very similar risk population, which is slightly against the common sense that we have, which is HBR is on the other side of the HTR group. Again, when we divided this into risk factors, we could see that there was an increase in the outcomes by the HBR. However, the increase was not shown in the HTR group. When we divide this into aspirin and clopidogrel, we could see that both in the HBR group and the HTR group, there was a significant decrease in outcomes by using clopidogrel compared to aspirin, showing that clopidogrel was superior compared to aspirin, regardless of the risk, which was defined as HBR and complex PCI, such as HTR. Again, when this was divided into 4 groups by the presence of HBR and complex PCI, we see that the highest risk reduction was in those patients with the highest risk, which is those patients with HBR and complex PCI patients, which means that clopidogrel was better than aspirin in the highest risk patients, which means that this agent may be better compared to aspirin in these kinds of very high-risk patients that we treat in the clinic. So this is the last slide of my talk. I would like to say that the host exam trial and the host exam extended trial proved safety of clopidogrel monotherapy over aspirin monotherapy in stable CAD patients. And of course, only Korean patients were included, but the Korean patients are also all Homo sapiens patients, as Western patients, and as other ethnicity patients. If ethnicity were to be an important issue in this trial, then ethnicity should have been stated as an essential factor in considering treated CAD in previous guidelines or previous recommendation papers, but there was never stated as a very important issue. And I would like to say that high-risk features outweigh the significance of ethnicity, while we can see that the host exam study was consistent in these high-risk patients. So I'd like to say that ethnicity may be a minor issue, but again, the ethnicity is not a very important issue that we should consider when interpreting a lot of randomized clinical trials that we perform in the clinic. Thank you for your attention.
Thank you, Dr. Kang. It's impressed by your saying that we are all human sapiens, Homo sapiens. And Dr. Merang and Dr. Dengas, thank you for joining our symposium late Friday evening and giving nice lectures. And this is open for discussion. And I'd like to introduce our panels, Dr. Chan Jung Kim and online, and Kim Tae-hun and Oh Kyu-chol, Im Sung-min, Jung Young-hun, Hwang Byung-hee. Please feel free to raise questions.
Hello. 안녕하세요. Hello.
네, 잘 들립니다.
Yeah. Thank you for inviting me this prestigious conference. I'm having a wonderful time in New York, Mount Sinai, and I'm personally thank you, Dr. Maron and Dr. Dengas. And my question. As Dr. Maron wonderfully summarized in her lecture, there was several very good strategy has been published in previous decades. But there was roughly two strategies. One is as Dr. Maron preferred, P2Y12 monotherapy after TCI, after initial phase. But there was another trials as we have like a thalassemia and the post-therapy issues. There's an aspirin plus less potent antiplatelet therapy. So my question may go to Dr. Maron and also Dr. Han. Which one would be preferable in after initial phase of acute coronary syndrome? after PCR? Can I have it? Yeah.
I can take that just after initial PCI, I feel very compelled to give patients potent P2Y12 inhibition because of the variability that we see with clopidogrel. And so in my mind, a P2Y12 monotherapy with a shorter duration of DAPT, especially if there's a high bleeding risk, is more preferable than going to clopidogrel or even clopidogrel monotherapy, which we saw not work very well in stop DAPT ACS. So I'm more reluctant in ACS patients to de-escalate to clopidogrel, especially if it's monotherapy.
Can I have your
Yeah, I agree with Dr. Moran. As I mentioned in my presentation, my default strategy for ACS patients is aspirin plus P2Y12 inhibitor, preferably Prasugrel in my case, for 12 months. If patients have a high bleeding risk or have minor bleeding or complains with breathability, I reduce the dose of Prasugrel or Prasugrel to clopidogrel. But the proportion of patients with HBR is not so high in Korean patients. In our SMART Day trial, the proportion of patients with precise DAPT score of 25 or higher was only 25%. And in the STOP DAPT2 trial, subgroup analysis, the proportion of patients with HBR-ARC was only 1/3. So in most patients, we can continue the adaptive aspirin plus potent P2Y12 inhibitors after ACS.
We have data regarding the prevalence of HBR in our PCI code. That is about 1/3. 2/3 are low BR, 1/3 is HBR, based on the host BR RCT enrollment status. But interest findings in our interim analysis, the instance of event of HBR is about 3-fold higher than low BR. That's actually HBR issue is very important. In this context, at least in South Korea, we prefer more lenient antiplatelet regimen than a stronger agent such as TICA.
Yeah, as an inventor of the concept of stage and paradox, I must be sorry for the doctors because I can make some hurdles to publish the excellent data from Korean society. Actually, I suggested this concept almost 10 years ago. My feeling is like this: the standard dose of Prasugrel, Ticagrelor would be too strong for East Asian, including Korean patient. Fortunately, now the concept of de-escalation and the abbreviation of that strategy is so widely accepted in Korean society and even in global society together. So, in this point, I would like to ask the question to Meran and Dr. Han. The de-escalation strategy is widely used, tested in multiple trials. How to think about that? The HBL patient is a good candidate for the de-escalation, or other patients no applicable for the de-escalation strategy? How do you think about?
I think in all things are possible for all patients, depending on the timing and when we're doing these things. In my mind, if a patient is a high bleeding risk and we're very concerned about the potent agents, we can de-escalate, but there has to be, if there is a complex PCI, I feel uncomfortable to go with a clopidogrel monotherapy. And I would want to make sure that they're at least responsive to clopidogrel, especially if there's a stent in the left main or bifurcation stenting or something like that. So I'm more reluctant and more nervous about de-escalating without testing. So I think,
there is a place for everything. You can go with potent agents alone without aspirin for some time in that early period, and then go down to de-escalate to clopidogrel, and then test them to make sure that they're actually responding.
Can I ask a question to the Dr. Dangas? You showed the data of ARTE or popular TAVI RCT. I think both RCTs results is not so important for us because ARTE just 200 patients for 3-month follow-up. Just message is DAPT increased bleeding, then aspirin, just immediate after TAVI procedure. Popular TAVI is also small sample size, just 1 year follow-up. The difference between DAPT and aspirin monotherapy is just difference of bleeding immediate after TAVI. But when you consider valve durability, stronger agent would be better than weaker agent based on Atlantis CT, 3D CT data or Galileo trial, suggesting warfarin is better than apixaban. Apixaban is better than DAPT. In Galileo, rivaroxaban is better than antiplatelet agent. Thus, with this context, I don't agree aspirin monotherapy is preferable to DAPT after TAVI procedure. Considering longevity or MACE beyond 1 year or 5 years, I think DAPT may be better than aspirin monotherapy. How do you feel such kind of proposition?
Well, I have to agree with you that the studies, there may be several, but each one of them, it's rather a pilot study. About 100 patients per group in the ARTE, just a few hundred in the popular TAVI, definitely not a lot. In order to be powered properly to answer this question is you need thousands of patients. So we're not anywhere near that. And I also agree with you that the difference they show is mostly related to the loading dose of clopidogrel. So that is very procedural, where they don't address at all if there could be a benefit or there could be a harm if you start the more potent therapy upon discharge. That's really the question we really want to answer these days. And I agree that this needs to be studied in the longer term because a lot of the benefits would be in the durability aspect, perhaps in follow-up echoes and things like that further down the line. But I think that the tolerability of these medications has been pretty good for the several months after the procedure. So I do think that perhaps even a monotherapy trial would be good in a larger scale. And clearly a large-scale trial is lacking from this field, particularly since TAVR has become so popular and that there are many procedures now involved with this type of device. There are plenty of devices, quite frankly, and the devices need to be used appropriately with a correct and well-tested medical therapy. And I think we're lacking. I agree with you. That we're not anywhere near. We can show slides of trials, but each and every trial, when you look at it, it's just a pilot, nothing more than that.
But guidelines support aspirin monotherapy after TAVI. So I think it is too far based on really weak evidence.
The evidence is weak. I agree with you, but there is a little bit of a momentum, and the momentum towards simplicity. And in that momentum, it's a best guess, I would say, and not really evidence, clear evidence. It's best guess. And a conundrum of small studies ended up. That's why in my concluding slide, what we know from these studies is that the loading dose has no benefit and potential bleeding. From then on, we cannot say really anything else. Now, what the guidelines say, and maybe they're overextending, maybe they are. And the American guidelines still talks about 3 months of dual antiplatelet therapy, and this is what we follow at Mount Sinai Hospital.
Dr. Dangas, several years ago, I attended the webinar of MBCG AF, where you gave a lecture. In the discussion time, you mentioned very low dose of edoxaban would be okay in preventing reflex thrombosis. So especially edoxaban 50 milligram. In 2000, in latest ESC guideline, all patients who received surgical AVR and should receive the warfarin for first 3 months, after then single antiplatelet therapy. So how about adopting this strategy in post-TAVR patient? The first 3 months or 6 months, very low dose of NOAC, and then single antiplatelet therapy after that. So what do you think about my opinion, my suggestion?
I think this is a very practical opinion, and I do think that the edoxaban meets the dose reduction criteria quite often in TAVI population because of age and concomitant risk factors of renal failure. So one can say that a 30 milligram may be a more frequent dose for this indication. And it would be adequate to prevent the halt and the other aspects when you study it in a larger scale. Somehow it didn't pan out in your study, in the Korean study, in the ADAPT, but I think if in the larger scale, perhaps these differences would be statistically significant. Perhaps it also has to do with the fact that the small halt in visualized in larger valves, and in the Asian population, the sizes of the valves are somewhat smaller, and perhaps this way you had less halt prevalence in the control arm than what we saw in the Galileo and apixaban populations. But regardless, I think that it's very reasonable to think that a short-term anticoagulation of a low level might be useful in our population. Because what we saw from Galileo and Atlantis is that the longer-term anticoagulation and the high doses and intermediate doses, it is associated with adverse events. But we can either limit the dose or limit the duration. And if you limit the duration, you also limit the side effects. And this particular early period, when everything gets endothelialized and perhaps clot is triggering more local inflammation or maybe hardening and pannus formation, if we abolish that, we may realize a longer-term favorable effect. So in general, I am enthusiastic about your approach, and I would like to see some studies about that.
Thank you. So, Dr. Meran, I have questions. I have long questions the result of ESA REACT 5 trial. In the ESA REACT 5 trial, prasugrel was superior to ticagrelor. So I still wonder this is true. So do you have your own interpretation of ESA REACT 5 trial?
I congratulate the investigators for doing the work, but I think that it was a complicated design with different issues. About 20% of the patients did not receive the assigned therapy. And I really don't think that you can show or there's any reason why you would imagine that there's a difference between prasugrel and ticagrelor. Honestly, I really don't see how that's possible. That needs to be repeated for me to believe it. And I also believe that the fact that many of these patients who were supposed to be on ticagrelor actually didn't receive it. And so adherence to the study drug was an important aspect that was being missed in that trial.
Yeah, the superiority of prasugrel in the ISARECT 5 trial might be due to by chance or difference in strategy in non-ST elevation ACS patients, but at least we can say prasugrel is not inferior to ticagrelor. Before ISARECT 5 trial, ticagrelor showed some favorable results compared with the prasugrel in terms of mortality or bleeding issue, but after the ISARECT 5 trial, the prasugrel is at least as comparable to ticagrelor. If the efficacy is comparable between the two drugs, prasugrel is much convenient compared with the ticagrelor, once daily regimen and the absence of some adverse effects such as dyspnea. So after ISARECT 5 trial, I prefer prasugrel to ticagrelor in real world in my practice.
Yeah, there are additional supporting core data supporting for ISARECT 5 RCT, such as RENAMI, AMI registry, and UK STEMI registry. Sample size is several thousand, more than 10,000 patients. Of course, it is cohort. The results of prasugrel-based DAPT is better than TICA-based DAPT, even in UK or Europe. Thus, most of the people supporting TICA just raise a kind of fault in running implementation of ISARECT 5 RCT, but I respect the result of ISARECT 5 RCT because there are many supporting data favoring prasugrel.
Unluckily, our session time is over, and we are waiting for next session. So thank you for Dr. Meran and Dr. Tengas. We all enjoyed your lecture. You are the leaders in this field. So we are looking forward to seeing you later, specifically offline in Seoul. And I'm going to close this session. Thank you for all speakers and discussion.
Thank you.
Good night.
Thank you.
Bye-bye.
Good night.
Thank you. Congratulations. Bye-bye.